Dear colleagues, my name is Sara.
I'm from Portland, Oregon, and I studied in Debrecen years ago, and right now I work in cardiology hospital for 2 years. I love Hungary, and that's why I'm here. And my vision is introducing innovative approach in medicine through translational research from bedside to bench and bench to bedside for my patients all over the world. And my mission is to collaborate to make the Semmelweis University cardiovascular medicine as a national leader in health for the purpose of improving the health and well-being of Hungarians and beyond. So the summary of my projects are as following. One is meta-analysis and systematic reviews. It's about comparing the rates of complications in leadless versus conventional pacemaker for right ventricular pacings. And the second one is real-life patient selections and indications of leadless pacemakers. And it's an international survey study. As a background, leadless pacemaker designed to be less invasive and with the fewer complications. The primary advantage of leadless pacemaker is the eliminations of several complications associated with conventional pacemakers, including infections, hematoma, lead dislodgements, and lead fracture. We use only in the case of single chamber ventricular pacing cases, and it lacks the defibrillations. 90% is smaller than conventional, and it has better cosmetic apples. The future of leadless device is promising, and one of the beneficial use is in post-TAVI patients. This is the future perspectives of leadless pacemaker, which we use combinations of both conventional and leadless together. About my first projects, which it is meta-analysis, the co-investigator and project students, thank you for both of you because they did the hard work. The backgrounds, the infections is one of the most costly complications that has very high mortality rate, 30 to 35%. And for sure, cardiac tamponade during and after leadless pacemaker implantations is a high risk as well. In one paper, there is no mortality difference between leadless and conventional. Leadless pacemaker were designed to reduce lead-related problems, complications, and the articles suggest that we have reduced infection rate, dislodgements, but higher tamponade rate. That's why we are doing systematic review. The clinical question is that, is the leadless pacemaker use associated with different rate of mortality, complication, and revision compared to conventional? And for sure, the PICO is based on these criteria. And the outcome for us is mortality, complication, revision, and infections, and cardiac tamponade. Hypothesis would be the leadless pacemaker has less complication than conventional. And for clinical implications, we are assessing the safety of leadless pacemaker. We used 5 databases in 2nd of November, and we used the following domains. We found out 126 of the full text articles, and right now we are in the level of data extraction. And the total, it was out of 6,440. The second project is about real-life patient selections and indications of leadless pacemakers, and it's international survey study. Leadless pacemaker reduced the major complication by 63% compared to traditional. In Honville Hospital, we started to use leadless pacemaker in 2014, while the FDA approved on 2016 and 2020. And per one survey in Europe in 2018, they understood that high cost of the device is the main reason that we are not using it that much in Europe. And 72% of them were hoping that we increase the utilizations in next 2 years. And this is the reason why we are reassessing that. The clinical questions is that which patient population served better by leadless pacemaker versus conventional? And the second question is what are the major barriers? The aim is evaluate real-life patient selections for leadless pacemaker implantation and identifying the major cause which prevent the widespread use. And the hypothesis is the high price, awareness, insurance company coverage, training, and experience of cardiologists using and implementing the leadless pacemaker is the major barriers of leadless pacemaker implantations. And as a technical point, we use self-made questionnaire, sending them to the network of arrhythmia societies, and we will distribute them between doctors. And the clinical implications is that more eligible patients will receive the leadless pacemaker. As an overall goal, we are planning to finalize our research in 2022, both of them. And as my personal quote, one life, one song. In 2017, I was awarded as the first place in narrative medicine, Northwest Narrative Medicine Conference in Portland, Oregon. So actually one of my hobbies is writing the poems. And I wrote this way: every heartbeat is a gift. And translating this message to us, that we are here, we are alive, they are the melody of our lives. And I hope the melody, this melody, bring peace, comfort, and happiness to all beings all over the universe. Wishing you all the best and great health. Thank you.
Congratulations. I'd like to ask you, what are some of the complications that you would expect to have with the leadless pacemaker, but not with the conventional one? And to whom would you rather advise the leadless one?
In what scenario we use leadless?
Well, what are the complications that are associated with the leadless rather than the conventional one?
Yeah. So basically, leadless is based on till now what we know is better, but the only point would be that based on some articles, the tamponade would be the high rate. So I'm trying to find the slides. The higher tamponade rate, that is we found it in the articles, but we are also trying to reassess.
And then what would be the subpopulation to whom you would rather advise the leadless one, not the conventional?
Yeah, so far till now, especially before the FDA approval, they used it in a very high mortality and high mortality morbidity patients, for example, above 80, or patients with other complications like dialysis and post-TAVI patients who are very old, like above 80 also. And so far the populations was in this category, but also they started to use in normal, I mean, if the indications is for those patients, they use it also nowadays. But based on the company suggestions, they use it in the AV block with the AFib conditions, especially for single chamber pacing, like right ventricular pacings with AFib complications. But we don't use it in dual chamber.
Mm-hmm. Thank you.
Sara, you have a huge amount of full text. So more than 126.
Yes.
Okay. Did you exclude the abstracts, the conference abstracts? Or they were also included?
Conference abstract?
Yes.
We kept it initially, but then we removed it.
Okay.
Yeah.
Okay, so these papers are all uses the same PICO framework, and you can extract this data and pull together. I mean, it's a huge amount of full text, I mean.
Yeah.
More than 100.
But I should draw your attention, we have lots of subgroups, because not all of them are the same populations of patients. So we have like valvular disease patients, diabetic patient, dialysis patients, patient above 80. So there are lots of subgroups. So hopefully we are doing the more subgroups, and it will be very unique by its own.
Okay, thank you.
You're welcome.
If I can ask the same thing in a different way, that are these papers mostly RCTs, randomized clinical trials? Are they randomized clinical trials mostly, or just?
Mostly, yes.
Yeah. So
no,
that's not a limitation.
Too much.
Yeah? So that is not going to be then that easy, I would say that. I mean, that to pull this together. I mean, because of the kind of just the different approaches. Just anyway, the other thing. I mean, when you use a kind of leadless pacemakers, I mean, the size of this unit which is in the heart, I mean, that must be bigger. So does it count at all? Does it cause any problem compared to normal wires which just kind of go there and then just stick it?
The size is like, they call it, it's in the size of vitamin D capsule. So it's not that big. But at the same time, well, we are eliminating the lead complications and also these pocket issues that is always there. You know, this, it will reduce lots of mobilities, especially for athletes.
Yeah. I mean, these are all assumptions, of course, but you will deal with this in your analysis, I assume.